All righty. Okay, good evening, everybody. Thank you so much for your patience and waiting for us to get started here. Welcome tonight to When a Good Knee Goes Bad. We're really happy to have you all here. Welcome back to anybody that joined us back in May for our first round. We had some really good success and great feedback with that webinar, so we wanted to do it again and welcome our new members to the webinar tonight. We're happy to welcome back Dr. Azer from Upstate Orthopedics. He's here to present with Damond Archung and Garry Campbell here with our team from Onondaga PT. Our webinar tonight's going to be about an hour long with information, and then we're going to reserve about 30 minutes afterwards to answer some questions. There is at the bottom of your screen a question and answer or a chat bar. Feel free to leave your questions in there. We're going to leave everybody on mute just so we can keep the background noise to a minimum. We will be recording your questions and we'll answer them at the end. So keep the questions coming along, and then please be watching for an email either later on tonight or tomorrow with some information from the webinar and a link to have a free injury screen with our PT team here to see if PT would be right for you. So without further ado, I'm going to hand this over to Garry to talk a little bit about some preoperative PT management.
There you go. Excellent. Thank you, Mary. I'll allow myself to introduce myself. My name is Garry Campbell. I've been involved with physical therapy for over 20 years, and I've been a member of the team here at Onondaga Physical Therapy for 17. I got my degree, my master's degree from Western Carolina University. I started out at Presbyterian Hospital down in Charlotte, and as I graduated, I moved back closer to home here to Syracuse. So thank you everybody for attending, and I hope to teach you some things tonight. So the knee joint is classified as a hinge joint, and it is made up of 4 different bones. So I have a model here of the knee. The 2 bones on the bottom part of the knee are the tibia and the fibula. The top bone is the femur, and there's a 4th bone that floats. Basically, it glides north to south as the knee moves in a flexion and extension pattern, bending and extending. The particular part I'd like to focus on tonight is the articular cartilage, which is the hard surface on the femoral condyles. And what happens with that is over years of your knee bending and straightening, that articular cartilage can come pitted. And it's that breakdown of the articular cartilage that reveals the soft bone underneath. When that soft bone is revealed underneath, it becomes inflamed, sore, and that's when you suffer from arthritis. Slide check. There you go. Thank you. So we're going to talk a little bit about prehab tonight. Damond is going to talk a little bit about the post-operative physical therapy, and Dr. Azer is going to talk about some surgical procedures. Preoperatively, people can come at any point in time to address their knee pain. It's a degenerative change, so it happens over time. And at any point in time, someone can come to physical therapy with a complaint of knee pain. As a physical therapist, we want to assess their knee range of motion strength and their pain, and hopefully get back that range of motion and function that they want to achieve. Here at the Liverpool office, where we're, I guess, broadcasting from tonight, we have aquatic therapy. I'm the aquatic specialist for the company. It allows me to get the patients that are suffering from arthritis in the water. Water has a property of buoyancy. So when you're in the water up to your chest, if you're a 200-pound person, about 80% of your body weight is floating. So therefore, only about 40 pounds of weight is going through those lower extremity joints, such as your ankles, knees, and hips. It allows people to get the exercise they need as they're going through the disease process. It's hard to reverse it. So we just hope to slow it down, and we slow it down by movement. As physical therapists, we are movement specialists, so we want to keep keep you moving the best we can. Arthritis in general is a vicious cycle. What happens is you start to develop knee pain. It hurts you to stand or walk, so you become less active. As you become less active, you become less strong. As you don't have that strength and conditioning, you just become less active, and that's that vicious cycle. What we want to do is reverse that vicious cycle. We want to work on your strength and conditioning. We want to be able to get you up, moving around a little bit more. And as that functional capacity increases, so too hopefully does your knee pain, and you're able to go back to some form of prior level of functioning, achieve those goals that you want to get back to. A lot of what happens when patients come is an education process. We want to teach you some exercises that will help you return to that prior level of function. Again, most people come to us with a first complaint of knee pain, but they also lack some form of knee range of motion and strength. A lot of times what happens is those degenerative changes. Will happen, and as you start to lose some knee range of motion, a lot of times you lose that ability to fully extend your knee, which will compromise your gait pattern and cause you to even limp further. Prehab wise, by the time you get to see someone like Dr. Azer, you can start very easily with some physical therapy, but a lot of times if you have an x-ray that shows some advanced degenerative changes and you're talking about a knee surgery, a lot of times he'll send you for prehab to work on just some exercises to do both preoperatively for 1 to 2 sessions, but also some of those same exercises are going to be the ones that you want to start at immediately after the surgery. So tonight I've developed an exercise program. I use onondagapt.medbridgego.com. It's an online service. If you type that into your web browser, even that website will bring you up, and there's an access code on there. You'll have the slides to your availability. So for example, if you were to type that access code into the web browser, it's going to pull up the exercises that I'm going to go through tonight. And it'll allow you to work on some of these yourself. Again, I'm not trying to diagnose anyone tonight, but these are some of the few very simple exercises that if you do have any kind of knee pain, it should help you work on just generating that initial strength to help you get back some function. I'm going to pause my camera here for a little bit as I set up for a little demo. And if there's any questions, maybe Mary could answer those at the moment.
All right. So like I said, there's a chat bar and a Q&A at the bottom. Feel free to place your questions in there. And if there's any that pop up right now, we'll certainly field those questions, and otherwise we'll keep them for the end. So I'm gonna pop the computer screen back over to Gary and Damon. They're just getting set up right now for a little demo for these exercises that you see here on your screen.
Perfect. Just tilt that down just a little bit to get your leg. Hello, I'm back. All masked up because now we're not quite 6 feet away. So the exercise that I have for you tonight, the first one I want to describe is called the quad set. And I have my lovely assistant Damon here with me, who's been nice enough to share his leg. So the first one is a quad set. And what we want to do is we just want to start to contract that quad, which is the muscle on the top of your leg. Like I said before, a lot of times that hinge joint doesn't completely get straight with arthritis, so you wind up with a little bend in it all the time. So this quad set's going to help push that knee straight. In the same sense, if there's any swelling within the joint, it's called joint effusion. It's going to help eliminate some of that swelling in the joint That swelling, if it's in the joint, can cause the knee to be unstable, and we want to push it right into a nice closed pack position, get it right nice and straight to allow for the greatest stability of the knee. So to cue up Damond to do a quad set, what I'll do is I'll just have him, sometimes I like to do a little tactile stimulation, but I'll just say, can you tighten up the top muscle on your leg, like you're gonna push the back of your knee into my fingers right there. Good. And you can see his knee goes straight down into my fingers, and even the bottom of his leg comes up off the table. This is a very good quad set. He's able to achieve just that little bit of extra hyperextension. The people that have a lot of arthritis that can't quite achieve that, a lot of times what I'll do is I'll take a little towel, because they can't get their knee straight. I'll prop it up a little bit, and it gives them a little biofeedback to push into the towel until they can get enough strength of that quad to really start to get it straight again. You can do this in long sitting like he is. You can also do it. The next picture is the person just has their foot on the floor, heels on the floor, toes pointing towards the ceiling. And again, you're just trying to tighten that quad to get the knee straight. The next important exercise is called the heel slide. Once we get that joint effusion starting to move and work out of the joint a little bit, we want to get it all the way out of the joint. And just a little heel slide is, I'll cue Damond just to bend your knee up. You slide your heel towards your buttocks, and then you straighten it back out. A lot of times with patients, depending on how severe the arthritis is, they have a very hard time bending their knee. We have a little tool in the clinic here called a stretch out strap. We can put it around the foot. And as Damond bends his knee up, he can use his hands to bend it a little bit further into that knee flexion. With arthritis, you want to kind of pull it up to the pain. You don't want to try to crank it through the pain, because you're just going to probably wind up hurting yourself some more. So again, it's just kind of, you want to do the patient, and Damond wants to pull it up as much as he can, but a little bit of extra pull on his hands will help get that little bit of extra bend. And the last one I have on the slide there is just called a straight leg raise. Again, we want to just work on the quad set. A lot of times when patients develop an antalgic gait pattern due to arthritis, they don't bend and straighten the knee as well. So they find it easier to kind of circumduct at the hip versus advancing with some hip flexion like you're supposed to. So this exercise works a little bit of that hip flexor muscle up here. So again, we're going to have them do a nice quad set, keep the leg nice and straight. We're going to have them lift it up and back down. Damond, if you could just put your right knee up there, bend it up. So a lot of times when I'll cue people up, a lot of times what I'll do is I'll just have them do the straight leg raise, and then just don't bend it any higher than this knee that's bent up. You don't really need to go all the way to 90 degrees. It's just starting to get that hip flexor. Perfect. All right. So those are the exercises that I provided tonight. Can we get back to the...
And we'll pause again real quick and switch over to the presentation.
Good evening. I'm Emil Azer. I'm one of the orthopedic surgeons at Upstate Orthopedics. Today I want to speak to you about knee pain. And really, the major points of the talk are going to center around mostly non-operative treatment, but also when the time comes for operative treatment, which would be knee replacement, what to do beforehand, what to do after the surgery in order to maximize your outcome, and to see how we can make your knee back to where it used to be or close to it. So let's talk about knee pain. Just a little bit of background about me. I have been at Upstate Orthopedics for 11 years. I do trauma and adult reconstruction, which means basically knee and hip replacements. You click? Not working. Where?
At the top there.
Oh, got it.
Google Docs.
1 second.
Google Slides.
Yeah, there it is.
Just click on the far right.
Where's the presentation mode? Give me 1 second, some technical difficulty. Okay, so at one point, maybe you were able to do gymnastics, or you thought you were like a Superman, or able to run miles or ski like this gentleman is in this picture. And what happens is, as you get older, as Gary mentioned earlier, with repetitive motion, the knee joint and all joints, but specifically the knee and the hip, they become arthritic, they get pitted, and they're not what they used to be. So really, we want to talk about why can't you continue with those activities, the gymnastics, the skiing, the running, the lifting heavy, or was I?
No, you're okay.
Okay. So, causes of knee pain: meniscus tears, ligament tears, patellofemoral syndrome, cartilage defects, fracture, infection, osteonecrosis, and arthritis. And we're going to focus on arthritis. Having a little technical difficulty. 1 second. Can you see the slides okay? Is it a big slide or is it a PowerPoint? Okay, but people are seeing it as a slideshow. Okay, so we're going to focus on arthritis. And as I said before, this is the pitting. This is the pitting. This is when the wear and tear. Other causes could be completely extraneous from the knee joint. That could be your hip. It could be your spine. That is something that when we are addressing knee pain, we have to make sure that these aren't the actual causes. So osteoarthritis. What exactly is osteoarthritis? What we'll start talking about is, what are the symptoms? What does a typical patient feel? Usually, activities are what bring these symptoms about. So at rest, usually people don't complain of much pain, maybe some throbbing, maybe some swelling, but really pain with activities. Stairs is huge. Rising from a stair or descending steps is what brings on the pain. Rising from a seat, stiffness. Maybe at one point in time, you're able to have full extension and flex the knee all the way such that your calf is touching your thigh. And that becomes limited. And that limited range of motion is one of the symptoms of osteoarthritis. Stiffness, that even if the range of motion is there, feeling a stiff joint is also a possibility. Now, walking with a limp is something that's usually late, but it could also be early in the course of the disease. And so when you have osteoarthritis, your doctor says you have arthritis. And the big question is, what can I do about it? Usually it's somebody more of a generalist that will tell you have some sort of arthritis. Maybe they'll get x-rays, maybe they get even MRIs, or maybe it's just physical exam. And you have arthritis. And the big question is, what do you do about it? Now, definitive treatment is usually a total knee replacement, meaning replacing the cartilage and some of the bone that's affected. And that is the definitive treatment, and that is when there is nothing else that can be done. But before that, we're going to talk about conservative treatment. We got to start slow. And the first things we do is the first four, which are very important. Weight loss. If you think about it, that the joints see your weight no matter what it is. You could be carrying heavy weights, you could be heavier, you could be muscular, you could be obese, and that weight loss actually translates into a great deal of benefit for the actual joints. Activity modification, that's a big one. If there are some activities that limit you due to pain, one big thing that can be done is that you could limit those. So the old joke about the doctor says that you have to tell the doctor, my hip or my knee hurts when I do this. Doctor says, okay, stop doing that, and here's your bill. There's a lot of wisdom to that, where if something brings upon the pain, we'll limit it. Walking aids. A cane, a walker, crutches can be used. Usually it's a cane in this case. And physical therapy. As we alluded earlier, there is a great deal of benefit to strengthening the muscles around the knee or a hip that can help alleviate the symptoms, impart stability. And in the case that the disease has gone so far that you need surgery, before and after surgery is very beneficial to the success of the surgery itself. We want to make sure that the muscles are strengthened before surgery, such that you would be able to participate in the post-operative physical therapy. There's other things such as medications, your NSAIDs, anti-inflammatories, your Celebrexes, your Mobic, your Advil, Aleve, Motrin. They're important, but these cannot be used. They cannot be used in excess. There are side effects. And then you have your joint supplements like glucosamine. Then there's other things such as SMARDs and DMARDs, and this is specifically for rheumatic type arthritis. These rheumatologic medications are usually prescribed by a rheumatologist. So again, as I said, weight loss decreases the force on the knee, may improve mobility, and reduce pain. This is pretty logical. Physical therapy. So what when we talk about physical therapy, and I will go into it with some detail, but I will defer to my colleagues, Garry, Damond, and Mary about these modalities. Ice, as simple as it sounds, is very beneficial and is utilized at home and in physical therapy gyms. Heat as well. Things that we don't have access to readily are things such as ultrasound, electrical stimulation, taping, exercises, and of course, the manual therapy is a huge part of physical therapy in itself. Massage is also utilized, and what they do is they can reduce pain, they improve motion. Sometimes that may not improve. Sometimes there's mechanical symptoms that you can't overcome without surgery. However, in most cases, this is something that can be very, very beneficial. Improving the strength and proprioception is one of the big goals of physical therapy. So what is proprioception? Your joint needs to know where it is in 3 dimensions. So when you strengthen certain muscles, that actually has an indirect effect with pain relief. And again, when it's time for surgery, physical therapy does help speed recovery time pre and post-operative. So Garry discussed some of the normal knee anatomy. I'm going to cover it very briefly. Talked about the femur, the tibia, the patella, and the fibula. The fibula is part of the joint such that some of the ligaments insert there, so it's part of the stability of the joint. The articular cartilage, which is the medical term for the slippery hyaline cartilage that gives you that the mobility of any of the joints in the body. And you have your cruciate ligaments, which are in their center, and collateral ligaments, which impart stability. There are 2 rings called menisci, and synovium is the lining. So the causes: referred pain, hip, back, or ankle, trauma, injuries, infection, or inflammation. So we'll forget about the trauma, the fractures, and the sprains and strains. That is a separate talk, and you can devote a couple of hours to each of these, even in an introductory talk. But the tears, that's where what happens with acute injuries, more or less, or fracture. But the knee osteoarthritis, that's where we're going to focus on today. You might have heard the terms bone on bone. And what happens is you get this pitting and fissuring of the cartilage, and as it gets eroded, the actual joint space narrows because the cartilage thins. You get a few things also that are seen on x-rays. subchondral sclerosis, which all it means is hardening of the bone under or above the cartilage, and you get cysts. Little fissures and pitting cause fluid to get forced into the bone, and you have little holes in the bone. You also have osteophytes, which are bone spurs. The body's trying to regenerate. It can't regenerate cartilage, so it makes bone. So as I said, these are your conservative treatments. There's also invasive treatments. We start with things such as steroid injections and the gel injections, which is known as viscosupplementation, and that can help in some cases. Then there are stem cells and what's called platelet-rich plasma injections. These are still in their infancy and may not be as efficacious at this point, and we really don't know what the right indications are for. The surgical options are arthroscopic surgery, and that's really reserved for when you have mechanical symptoms and when you actually have tears of the meniscus or cartilage rings that block motion. There are things such as subchondroplasty, which I will touch upon, which basically is a minimally invasive technique of strengthening the bone underneath the cartilage. And then what we're going to concentrate on is total and partial knee replacement. As for medications, you have the NSAIDs, your anti-inflammatories, and COX-2 inhibitors, which are similar. Tylenol, topical anti-inflammatories, and these can be also lidocaine patches and anti-neuropathics that work on nerve pain, and they reduce inflammation, and they allow for PT, and they they allow for patients to actually break through their inflammation cycle so they can participate in physical therapy. And why I put the just say no is because one thing that we do not use in most cases is narcotic medications for arthritis. Viscosupplementation. This is the lubricant gels that we talk about, and this really is not the most reliable in terms of our outcomes. They do pretty well, but you have to have some cartilage left. So if you're completely bone on bone, I rarely recommend it. I think a steroid injection just does better. Stem cells and platelet-rich injections. These do have some good literature that support potential to heal damaged cartilage, and there are some studies that show greater than 50% relief. However, the results are not consistent and they're very costly. Similarly with PRP, platelet-rich plasma, they do work in some cases of soft tissue tears, tendinitis is a golfer's elbow, tennis elbow, rotator cuff. Not very popular in treatment of arthritis and not very efficacious. Now, subchondroplasty is one of those that I think is a great idea, and when it works great, but also not reliable in most cases. This is an MRI, and this white stuff here, this is inflammation or edema, but more often than not, this is actually a microfracture. And what we do under X-ray and by placing an arthroscope in the knee, we're able to locate that area, inject a type of cement in there that allows the bone underneath here to heal, and it gives you structural support. And it doesn't restore the cartilage, but it does improve the symptoms from time to time. So if all else fails, we are left with knee replacement. There's a couple of types of replacements. And what the goal of these replacements are to resurface the diseased cartilage that are all pitted with metal and plastic. You want to realign the axis. Now, the center of the hip and the center of the knee and the center of the ankle should be roughly one line. And so sometimes you get bow-legged, sometimes you get knock-kneed with arthritis. So in this case, when you have these deformities, you're able to straighten out the knee back to where it's supposed to be. Now, not everybody's born with a exactly straight axis, so there is some leeway. And the other thing is stability. An unstable knee where the cartilage, where the ligaments are lax, we can tighten up those ligaments and and by enhancing the stability or restoring the stability, you will enhance function. So what is a total knee replacement? So this is a classic picture of tricompartmental arthritis, which mostly is in the medial compartment, which is the inside. You lose the cartilage height, you lose even some bone. The ligaments here are contracted and tightened. These are lax, and it's kind of a vicious cycle where this is bow-legged and becomes more and more bow-legged. So part of the surgery is to correct that, to resurface the worn cartilage, and the second part is to restore the axis. The third part, which is either a consequence of the surgery, but it is also a big part, is ligamentous balancing and enhancing stability. So in this case, we want to straighten this knee out. We make a series of cuts, and after the cuts are made, we use metal and plastic to resurface it. This is what it will look like. As you can see, this is the inside, and the inside has been restored. And you can start seeing a gap here. This gap looks like a nicely balanced knee. And this translates to this drawing: metal, metal, plastic. And the plastic is a polyethylene that's used with very good wear characteristics, such that it has the longevity that we expect to be up to a couple of decades. Then there's also unicompartmental arthroplasty, and this is really reserved for isolated damage to one compartment. There's the kneecap compartment, there's the inside and the outside. This is used from time to time on the right patients. So what can somebody expect? Somebody can expect that this is major surgery and there's risks, bleeding and infection. There is a medical clearance that's going to be required, especially with older patients. And it's usually inpatient surgery, but I would like to circle these and highlight these. These are changing by the minute. It's now mostly outpatient overnight stays, and the 3 to 5 day hospital stay is a thing of the past. That is exceedingly rare now. Most of my patients leave the next day or even the same day. So there's supposed to be a red circle around it and an X, but I can't get that to work. And one of the big risks are blood clots that we give chemoprophylaxis, meaning medication to prevent that. But it's still an event that happens from time to time, and really, even with anticoagulation medication that thins the blood, people still get clots. And the other thing is antibiotics, because to try to prevent infection. One thing that I'm very excited about is our robotic platform. It's called the Mako. Mako is, we've been using it. It's been around since 2007. We've been using it, I believe, since 2013 or 14 for partial knee replacements, total hip replacements, and total knee replacements. And basically what it does is we're able to match the right size and preoperatively plan your surgery before the surgery. So we get a CT scan and it goes into a computer and makes a 3D model. That 3D model we're able to translate into real life. There is accuracy and precision that you can approximate with traditional surgery, but it really is a little arrogant of me to say that I can beat the robot in my accuracy. So this is what it looks like in the operating room. There's a monitor, and this is the robot. And basically, we use tactile, visual, auditory feedback, and real-time data to prepare the hip joint and the knee joint to obtain the desired orientation and accuracy. If you're a candidate for total knee replacement, you're also a candidate for robotic total knee replacement. And basically, one of the goals is you want to preserve healthy tissue and bone, facilitate optimal implant positioning and realignment of the axis, and also it's a more reliable recovery, and potentially a shorter hospitalization and earlier mobilization. And so this is some images from our interface. And with our total knee, we started in first quarter 2017. This is an old number. We've done much more than 400 total knee procedures. And I offer it to my patients whenever I can. We also have what's called a Swift knee in our program, which is an outpatient. It's on an outpatient basis, and we basically target younger patients who are healthier and mobile. Not everybody's a candidate, but when you arrive at 6 a.m., you're usually home by 3 p.m. And these are the younger, healthier, ideal patients. And the physical therapy involved in prehab is key. And so you're discharged home to begin outpatient therapy from there. And so with all these knee replacements, I usually allow people to do whatever they were doing before. So if you were just playing golf, taking walks, even slight running, I would allow you to go ahead and do that. Would not start anything new like this gentleman is doing. And usually patients are very happy with their level of activity post-operatively. There are risks, and it can include trouble breathing, reactions to anesthetic, bleeding, infection, scarring, and even death, exceedingly rare. Joints can get stiff, and that's involves patient factors and issues with the joint itself, nerve damage, blood clots, as we talked, heart attack or stroke. And these are inherent to all major surgeries, but it is something to be considered as well. Thank you.
All right, thank you so much, Dr. Azer. All righty. So what we're gonna do now is just take a second or two to transition over to Damond so he can present some information regarding post-operative PT management.
Alrighty, so we're going to talk a little bit about post-op timeline with total knee replacements. My name is Damond Archung. I'm a physiotherapist here at Onondaga Physiotherapy. Little background, I won't bore you too much, but I went to Nazareth, graduated in 2018 with my doctorate of physiotherapy. I've been treating here at Onondaga Physiotherapy for the past 2 years. And we're going to get into, again, a little bit about the post-op timeline of all this. So, as Dr. Azer said, knee replacements, you're not staying too long in the hospital anymore. That's gone to the wayside. Even this 2.5 days is probably a little bit generous with how much time you have inside of the hospital. Like he said, it's really same day, next day, 2 days max, then they're trying to get you out. So that's a pretty quick turnaround. And because it's such a quick turnaround, depending on your ability afterwards, it may change where you go. So that all depends on how much function and how much support you have at home. So say you get out of the hospital, say we got a generous 2.5 days and you're just not quite there. Functionally needs a little bit of help. You don't have as much support around the house. You just need a little bit of a bridge to get you the care that you need before you're ready to be fully independent with the home stuff and able to get to an outpatient orthopedic clinic such as Onondaga Physiotherapy. So what they'll do there is either make the decision to go to a skilled nursing facility, or they can give you the support that you need during that time, or they'll send you home. And if you're functional enough and you have enough support there, but you're just not able to get out into the community, into the outpatient setting, then they'll send you for home care physiotherapy. Regardless, it's a very short period of time. Most people get back from the skilled nursing facility within a week or two. During that time, you're basically doing PT every single day. And at home care PT, so you're at home, but you're not able to get to the orthopedic outpatient clinic. You're going to be there for about 2 weeks home, doing home exercises where PT goes to your house. and they do that every 2 days or so, depending on what you need. So generally speaking, orthopedic outpatient clinic physiotherapy starts by week 3 or 4. But it's really important that we get on the ball earlier than that. And I'll show you why in the next couple slides. So knee bending range of motion. So when we first start out, we really focus on actually knee extension more than the knee bending. That's really important for most functional activities, and it's probably a little more important with functional activities than the knee bending. Having said that, that usually normalizes within the first couple weeks. So the rest of the physiotherapy really focuses on the knee flexion, because you need that for a lot of other functional activities. So there's some degrees here, a little table on the left side of your screen that kind of talks about how much knee motion that you need for various activities. And this may not mean a whole lot to you right now, but for the most part, we're going to demonstrate, Gary and I, how significant some of these degrees are. So going up and down stairs. So we need 83 degrees to go up and about 90 degrees to go down. So 90 degrees is that basically a corner. So right, perfect 90-90. You need that at least to go down the stairs efficiently. Sitting. So sitting up from a chair or standing up from a chair, you need about 93 degrees. Tying your shoes need a surprising 106 degrees, which that surprised me when I learned that back in the day of 2.5 years ago. But tying your shoes needs a significant amount of knee bend to it. And then kneeling, you need about 90 to 115 degrees. So somewhere within that range. And it's pretty common that even though you get that range to kneel on that new knee, you end up getting some knee pain still, despite all the rehab and everything else. It's very common. Sometimes those areas just stay sensitized for a little while. And that's nothing to be worried about too much. It's just part of the course, unfortunately. So post-op range of motion. So range of motion means how much you can move your knee. Again, we're going to focus on the knee flexion, so how much you can bend it in this presentation. But for the most part, how much knee bend that you get when you first get out of surgery really can kind of project how well you'll do in physiotherapy as well. So, and how hard you work in physiotherapy can also help get those knee numbers or the knee bending back a little bit quicker, a little bit less painfully. So it's really important that you start the rehab early on. And there is some literature to suggest that the more bend you have going into the surgery, the better off you'll be going out of the surgery, because there's some muscle memory and everything else. But so on average, the average knee replacement, you'll end up having about 85 degrees right after surgery. 85 degrees is a pretty good number right after surgery. And then that will slowly but surely improve after about 40 days to 110 degrees, as long as you're diligent with your home exercises, moving around, and doing the rehab that you need to do. So in about 40 days or so, 110 degrees, that is kind of what we're expecting. 120 degrees, that's the gold standard for most protocols. So we would love to have 120 degrees. That gets you a ton of function, but 110 degrees is pretty good too, and they'll give you most things that you need. So this next little bit here, Gary and I are going to just demonstrate a little bit of the sit to stand, so standing up from a chair, and why it matters with how much you can bend that knee compared to someone who may not be able to bend the knee as much, and might explain some things first thing out of surgery when you have a little bit limited knee motion, and you're able to, well, you're not able to get up as easily as you used to. So we're going to put a little bit of a pause on the share so we can get set up for a couple seconds here, and then we'll be right back with you. So hold, please. Alrighty. I think everybody should be able to hear me at this point. I'm going to tilt this up a little bit more. That's better. Alrighty. So Gary here, we switched places. Now he's my lovely assistant. So thank you, Gary. This is something called a goniometer. You guys don't have to worry about that, but this tells me how many degrees of motion Gary's going to have. So you'll get real familiar with this in rehab, but we won't spend too much time on it. But today we're going to start off with Gary's going to be at about 85 or about 80 degrees of knee motion. So a little less than what most people get right after surgery. So Gary, we're going to set those knees. So bring it forward a little more. And that looks pretty good. As you can tell, Gary's pretty good with his knee angles because he's been a therapist for quite a while. So good job, Gary. So Gary, when you're ready, I'm going to have you try to stand up from this chair without the optimal 93 degrees. So with a little bit less motion. Pretty far back. And Gary there was able to do this. He's a pretty strong guy. He also doesn't have any issues with his knees. So, but as you can tell, it was kind of a struggle, and he has quite a bit of strength, and we may not have that right out of surgery. So Gary, next one we're going to have you do is bend the knee back, and we're going to get to that 93 degrees. That minimum requirement for the standing up and sitting down to be quite a bit easier. So when you're ready, Gary, I'm going to have you try to stand up again. And right back down. Beautiful. And that looked a lot smoother.
Yeah, I didn't have to put my arms out quite.
Yeah. Didn't have to use that counterweight there. Gary, how did it feel?
That was pretty good.
Was it better than the first one?
Oh, absolutely.
Perfect. And I swear this isn't a scripted response here. He's being honest. So next one I'm going to have you do is bend it back a little farther. So now we're going to get a little bit more motion. So a little farther. So we're going to be about at 100 degrees. So now he's really able to get those feet underneath him. So Gary, I'm going to have you stand up one more time for me. And right back down. And as you can see, that was a lot smoother. Gary's face is a lot less red. How did it feel, Gary?
Yeah. If you notice, the second time my elbows came out, that time I was able to hold them right to my chest.
Absolutely. So no compensations. He's able to get up and back down pretty easily. So Gary, thank you so much. You've been a lovely assistant. And we're going to switch back over to the main presentation. So we'll be with you in another couple seconds as we transition.
All right. How's everybody doing out there? Just checking to see if anyone's got any questions. The chat box and the question and answer box you can use for any questions you have for the team.
Alrighty. Good. Okay. So back to the main presentation here. I'm going to skip through some of this stuff as I know we're running close to time here. But I want to talk a little bit about some return to sport and return to exercise. So sometimes this is something that's really important to people where they were wondering, when can I get back to doing those sporting activities I did when I was 20? Or when can I get back to doing the sporting activities I did this past year even? And there's some different nuances here. One thing is, although we call it a new knee, a total knee replacement, you're not getting the same function that you had back when you were 20. It's not necessarily a full reset. Generally speaking, the amount of activity that you were able to do within the past year leading up to that knee replacement is about what you're going to get back. The goal for knee replacements isn't necessarily to give you brand new skills you never had in the past. It's more so to do the same thing you're able to do before with a little bit less pain. And that's what the important thing is here. So if you're not participating in a sport currently or a higher level activity within the past year, it's unlikely that you'll be able to start performing these skills in the future. But again, it's not impossible. I'm not going to say it's impossible. It's just the stats are against you. If you work really hard, there's some potential there, but it's going to be a little bit rare for that to occur. And if you do sports currently, even though you have a pain in the knee, about 75% of people won't achieve the same performance level of sport after surgery. So you're still able to do the sport. You're still able to do what you want to do. You may not have as much performance. That's because there's some new hardware in there that your body needs to get used to, but you're still able to do so with quite a bit less pain and a little bit more quality of life. So sometimes that's worth it. And how well you can enjoy the sport when you're having a lot of pain, that's questionable too. So some factors to think about here is age. So obviously the younger we are, the more activity we're probably participating in and the quicker we heal. So for the most part, the younger we are with the surgery, the better the outcomes are for returning back to sport or exercise. Motivation, this is not easy to get back to. And physical therapy is not necessarily easy. And there's days where you're not going to like us too much as therapists, but if you stick with it, we'll get you where you need to go. And you'll be a lot happier at the end of the result. So the more motivated you are, the more likely you'll return to sport and that physical activity. And again, that sports participation 1 year before surgery. Weight is a big thing, as Dr. Azer touched on a little bit here. If you're a patient who's had some weight discussions with your doctor that maybe there's some overweight happening, some obesity, it's really important not only just for knee replacement outcomes, just for longevity and life outcomes in general, to start working on that, getting down to a healthy weight. And that can be a little bit challenging, especially for those of us who maybe never had to worry about that in the past. So that's where maybe consulting with a nutritionist or a dietitian can help you achieve those goals. So you have a lesser chance of diabetes and high blood pressure and really major health concerns in the future. And also is going to help your joints feel a little bit better too. These are just some general recommended exercises after the knee replacement surgeries. Now, this isn't a definitive list. These are just some quick examples. So low impact activities for the most part. And then there is some thought where you can get back to a little higher level impact activities, but that's at your surgeon's discretion. So I'll leave that up to Dr. Azer to talk about with you if you have a consultation. So walking, obviously, this is one of those things that people can get back to no matter what. Regardless of how well you did it in the past and up to the last year, that's something that we really focus on here in physical therapy. It's really important for a healthy lifestyle, and it can be really good cardiovascular exercise. And obviously we have our golf. Everybody loves golf and wants to get back to that. Dance, bowling, biking, swimming, gardening, all these things. And gardening is a low impact activity. And sometimes, depending on how people do it, it could be pretty intense exercise and possibly a sport. I've seen some people out there with those garden shears going to town. So that can be a little bit of a challenge to get back to. And then just to end here, I always like to end this stuff with a quote. I am who I am today because of the choices I made yesterday. So that's Eleanor Roosevelt. And that really, thinking about today, the changes that you can make today to make your life better in the future. Just because you have osteoarthritis doesn't mean you're going to necessarily need a knee replacement tomorrow. There's a lot of stuff that we can do to make you feel a lot better sooner. But if we do end up needing a knee replacement, I would suggest getting a consult with Dr. Azer or their Upstate Orthopedics, and come in to see us for a consultation for knee pain and everything else until you get to that point. And even after, we love to work with you over here on Onondaga Physical Therapy. And thank you for your time. And we'll go over to Mary now. We're going to get into the Q&A of this presentation. So we'll start with questions. So Mary, you can take it away.
Awesome. Thank you so much, Damon. Thank you, everybody. Thank you, Dr. Azer, Garry, Damon, for all the awesome information you've presented out here tonight to the group. We're going to stay on for a little bit and see if anyone has any questions that come in. Like Damon alluded to at the end, we do have an email coming to you guys tomorrow or later on tonight with the email that you shared with us. There is a post-webinar survey with some questions. There is a question at the end, or an area at the end where you can ask a question. Say, you think of something later on tonight or tomorrow that kind of pops into your head with any of the information that we've shared today. Certainly pass that question along to us and we will be certain to reply to you. We also have the recording of tonight's webinar available, as well as the exercises that Garry and Damon presented. Those will be available in your email as well. We also have the opportunity, like Damon alluded to, is what we call an injury screen. This is the opportunity to have a free 15-minute appointment with one of our physical therapists to discuss if physical therapy is right for you. If it would be anything regarding knee pain, but certainly any other ache or pain that's been bothering you and you want to ask a physical therapist for some advice. Let's see here. Just checking the chat and the Q&A, and I'm not seeing some questions popping up, so we'll just kind of hang here for another minute or so. But I want to thank everybody so much for spending your evening with us here tonight, and I hope you learned some valuable information. We really appreciate you signing on. We also are hoping to do some more webinars in the future, so if you have a topic idea that you'd love to hear more about, please share that with us as well, so we can continue to help everyone live, work, and play better. All right. Well, thank you again all for coming out tonight, and I think we'll probably be signing off here at this point. Thank you so much. Have a good evening.